Good afternoon, everyone. My name is Deborah DeBruin, and I direct the Center for Bioethics here at the University of Minnesota. And I want to welcome you all to today's Ethics Grand Rounds. We're really excited about this talk and grateful that Dr. Allen has agreed to join us today to share her expertise. I want to begin just with some announcements, some housekeeping announcements. Next slide, please, Kayleen. So at the end of the talk, we will try to leave ample time for discussion with Dr. Allen today. For questions, please use the Q&A function that you can find at the bottom of your screen. We will monitor the questions in the Q&A and we'll address them after the talk. You don't need to wait until after the talk to type your questions into the Q&A function though. So whenever a question occurs to you, feel free to put it in and we will address it once the talk is over. If you have any technical issues, and we all know that those do occur in the Zoom age, please feel free to use the chat and our support staff will address those with you one-on-one. Biomedical engineering students, you can email the email address on the slide there, the Center for Bioethics' general email address, bioethx@umn.edu, to indicate your attendance so that you can get credit for today. For those of you who are interested in receiving interprofessional education credit for attending Grand Rounds today, our staff will be in touch with you by email after the talk to send a link to the information about what you need to do to get IPE credit. So keep an eye out for that. All attendees will receive that email, but you only need to follow up on it if you want IPE credit. Next slide, please. I want to thank our co-sponsors today. The center tries very hard to partner on all of our programming with partners across the university and sometimes outside the university. Today's co-sponsors are the U's program in Health Disparities Research, the Clinical and Translational Science Institute, the Med School, the School of Nursing, the Office for Public Engagement, and the School of Public Health. We're really grateful for the partnership of those programs. Next slide, please. So now, without further ado, it's my real honor and pleasure to introduce you to Dr. Michele Allen, who is our speaker for today. Dr. Allen is the director of and endowed chair of Health Equity Research, the co-director of the CTSI's Community Engagement to Advance Research in Community Health, and an associate professor here at the university. Her research focuses on community-based participatory approaches to developing and implementing health promotion and tobacco and other substance use prevention interventions for adolescents of color and those from immigrant communities. Dr. Allen is a leader in the science of participatory research and increasing capacity on both academic and community sides for research collaboration. She has led multiple studies funded by the National Institutes of Health, the American Cancer Society, and other large foundations using participatory approaches. As a PI on a National Cancer Institute-funded T32 on Cancer Health Disparities, and an R25 designed to support the academic persistence of high school and undergraduate students underrepresented in science, Dr. Allen works toward fulfilling her commitment to enhancing the diversity of the research and clinical workforce. Dr. Allen completed med school at the University of Minnesota and a master's degree in sociology at the University of Wisconsin-Madison, so she brings really interesting expertise to these issues. She was a Robert Wood Johnson Clinical Scholar at the University of California, Los Angeles. She spends her clinical time serving families at the Community University Healthcare Center in Minneapolis. I want to say that the university really highlights research ethics issues during the month of March every year. Obviously, those issues are relevant throughout the year, but March is designated as receiving sort of special attention for research ethics issues. And this academic year, the center has really focused on equity issues in our programming because we believe those issues are really critical. And I think that Dr. Allen's talk today is a sort of a beautiful combination of those concerns around ethics in research and equity. And so at this point, I'm going to turn things over to her. And Dr. Allen, thank you so much for joining us today.
Thank you for having me. I really appreciate the opportunity. And I really do see this work, let's see, at that interface between ethics, community engagement, and innovation. So I just want to get a confirmation that everyone is seeing my slides and not my notes page.
It's beautiful. Thank you.
Okay, great. Thank you. So I'm really sort of speaking from both of these roles, well, multiple roles, but as a director of the Program in Health Disparities Research and newly in my role as co-director at CEARCH, which is the community engagement core of the CTSI. So you'll kind of hear me refer to both. And I think that what the timing of this is really nice, as this opportunity to be part of the CTSI has allowed me to really think about some of these issues through a more institutional frame. So for those reasons, I really appreciate being here today. Okay, so I want to start by just framing my talk today as a description of my now almost 15-year journey through this path of community engaged research. And on this path, I've walked with some of the community partners that you see listed here. Some of them I've had deep long-term collaborations with across multiple studies. Some of them I've sat around the table with just a couple of times, and you know, just that, even that was enough to have a few insights that have really sort of changed how I've thought about community engaged research. And I also, so specifically among the community organizations that I'm going to reference a couple of times today, I want to call out the Cultural Wellness Center. So they have co-sponsored with the Program in Health Disparities Research and a number of School of Public Health colleagues across the university, along with community colleagues that the Cultural Wellness Center has brought together, a community research ethics board, which has really, for me, been a kind of transformative opportunity to just sit around the table and think through some of these issues around research, around ethics, around making sure that equity is at the forefront of how we're working together. I also want to mention my BIPOC colleagues who are always, despite my focus on this issue, 3 steps ahead of me, and so are always teaching me. In particular, Veronica Svetes, Brooke Cunningham, Mary Owen, Rachel Hardiman, and others. And then also our BIPOC staff that I've had the opportunity to work with. Mai Kao Hang, Maya Kashawa Her, Zed Pitts, Kushik Paul, and even the insights of a very new staff member that we have, Renee Bonijet. And I also want to just mention also the leadership of Anna Nunez in the medical school, who I think has really sort of helped us to kind of take a leap forward. And that leap forward, I think for me, and which is probably true for many of you, that's happened over the last year, is really resulting from some of the institutional awakening, opening opportunity that unfortunately came at the cost of the life of Mr. George Floyd. So since his murder, I think it has caused me and many of us to ask, how can I lean into equity work in a more intentional way? What am I doing that's helpful or harmful? What do I need to do differently? And so that it really, in combination with kind of some of this institutional reflection, and I think being of the age that I'm, seeing kind of some of the lessons learned over the years I've been doing this is really sort of what I want to think through with you today. And I would say that the other piece, again, that's come kind of driving some of this is some of the work that's primarily been led by BIPOC faculty of color across the nation. That's really sort of asking the question, if we continue to do the work the way that we've been doing it, are we going to be able to really have an impact on health inequities? And this is one of my colleagues who has written a piece that I reference a lot. So there's 4 generations of health disparities research that Stephen Thomas wrote a number of years ago. He wrote he wrote a description early on the first and second generation, but then really in this latest piece is calling us to both take community engagement and, in this case, critical race theory, and really start asking the hard questions about not only from a community perspective, are we asking the right questions and doing the right research, but is our research process contributing to equity? In what ways do we need to critically rethink the way that we are actually doing the work? This type of work is also, so I'm putting this out there to say that what I'm proposing and talking through today is not new. It's a bunch of pieces coming together for me, but it's not new. So I would also speak to one of the co-sponsors. The office today, the Office of Public Engagement, has brought together Indigenous scholars to really think through a series across a couple of years around decolonizing research from the Indigenous perspective. So, and then listening to community colleagues, the Cultural Wellness Center has really sort of also called me to take this critical approach to thinking about how do we rethink the research process in a way that allows community to reclaim community knowledge as a path to wellness. So who this is new for is a lot of us who do clinical research, clinical trials, more basic research, translational research, and a lot of the research that we aspire to have funded by the National Institutes of Health. So in sum then, what we're going to talk through is these framing questions for the talk. What are the ways that community engagement for equity might differ from community engagement for innovation? And this is really sort of speaking to the way that I have always framed my work, is that bringing community voice in creates a better process that is going to create more innovative solutions, and solutions that are more likely to be impactful and effective and more likely to be sustained in community. But does that always and necessarily get us to equity? So then the second question is, if we are to take some of the community concerns and criticisms of the research approach seriously, what tension points arise? And then third, then, what are the implications to both academics and community if we work to address and play with those tension points? So I think I'm going to somewhat get at answering questions 1 and 2, but I'm really hope you are not dissatisfied at the end. We're going to come back to these questions, and I think really talk through what are potential solutions and answers to question 3, because really sort of I feel like within the work that we are doing in health sciences and in across the units that are served by the CTSI, for instance, we have a lot of exploration to do to understand what I'm proposing today might mean for us. So community engaged research, this is a definition of community engaged research that the CTSA consortium put out a number of years ago. And I think it is a very reasonable and a perfectly good and adequate description of community engaged research. It really speaks to working in partnership together with community, addressing issues affecting the well-being of those people. The purpose of it is to build trust, bring people together in a better way, create better communication. So equity is implied in that definition, but it is not explicitly stated. And then the framework that I work from, which is community-based participatory research, in this case, sort of articulated by Barbara Israel, is similarly a comprehensive and a well thought through approach to working together, where equity for CBPR researchers is really implicit in all they're trying to do. And in some cases it's talked about explicitly, but in my mind, in order to kind of move this dial, we need to be thinking about it in even a clearer and more explicit way. So this is a long list. This is 8 principles of partnership that were articulated really based on Barbara Israel's work, but kind of redefined and reshaped a little bit through some work that the Program in Health Disparities Research Community Academic Board did with Salamo Partnership for Health and Wellness and some other community agencies. So you can see that principles of equity are really outlined here. So shared identity of a community that requires ethical protections. Our community partners felt that piece of really calling out ethical protections for a community as an entity was important. The equitable involvement of partners at all phases, paying attention to social inequities, really understanding those contextual factors rather than individual behavior as contributors to health. But again, the explicit articulation of achieving equity as a goal, while it's absolutely held and is at the forefront of what we do in PHDR with our board, is not stated explicitly. So this is a slide that I've used all the time over the years to really talk about why should those of us who do clinical research, NIH-funded researchers, use a more participatory approach. And really, what it says is that innovation piece. It sells the innovation piece, right? That we've had problems with uptake, and that's because of interventions, and that's because there's a mismatch between what communities need what community organizations need and what we're doing. And so if you involve those end users from the beginning, you're going to create better research and get better research outcomes. So that is true, and I still do believe that. This is another slide that was developed by a number of folks here at the U years ago, and it really sort of talks about, and I use this in training all the time, the degrees of engagement, community engagement in research. And I often say, it's not so much that you can't be placed somewhere along one of these degrees. What's most important is that you're aware of how engaged your work is and that you're articulating that to community partners. And that the more you move towards a participatory approach, that increasing opportunities there are for an equity orientation. And part of that is really creating more opportunities for community voice to be central to what you're doing, and opportunities for capacity building, opportunities for learning on both sides of the partnership. The deeper the collaboration, the more likely those things are going to happen. But I think it still raises a question of, does the arrow go far enough? And so this is why I asked this. So in our conversations with the Cultural Wellness Center through the Community Research Ethics Board, I've come to understand the Cultural Wellness Center's centrality of culture in the way that they do the work, their work. So this is their definition of culture. It consists of practices that people create to give themselves continuity and cohesion across generation. Culture consists of a set of highly patterned, unspoken, implicit rules, behaviors, and thoughts which control everything that we do. And what the Cultural Wellness Center does is it sort of walks people through cultural self-study. And this is across multiple cultural groups over time, both sort of African heritage cultural groups, Indigenous heritage cultural groups, European American heritage cultural groups. And the process of the self-study is, I think, slightly different in some ways, but sort of parallel across the groups for others. The idea is it builds understanding, identifies community knowledge, or for those of us who are white, it makes explicit for us what part of our, what we're bringing to the table as being our community knowledge. And so really that is, called out by the Cultural Wellness Center as rationality, technology, our Western worldview, and a lot of the things that we sort of are inherent to us as Western traditionally trained scientists. And then the question is, when those cultures sort of come into contact, what happens and what is the result? So those tension points of having a cultures who within the cultural wellness frame, where knowledge production is sort of identifying cultural wisdom, research has that definition to it. What happens when these different cultures come into contact with each other, and how is benefit generated and how might harm be generated? So this is my first pass to kind of think about how some of these buckets or groupings might line up against each other. And so on the left is that this kind of more more, traditional engagement for innovation, which engages those most affected by the problem, those end users. It should be assets oriented, so building on community assets that are already out there. It has the opportunity to design trials that might reduce burden on community participants. It might generate novel clinical endpoints or patient-oriented outcomes. So those are some of the types of benefits that we talk about. Engagement for equity sort of takes some of that critical theory viewpoint, talks about centering at the margins, and so making sure that the community voice we're listening to is the one that is the most marginalized and most likely to be negatively affected or experiencing mistrust in the research process. It would frame an equity orientation and equity practices as part of the work. And it might require some institutional power shifting where you have a balance between community and academic decision-making. And benefits might be novel action-oriented outcomes. So this engagement for transformation really sort of speaks to culture being at the forefront, as I described from the Cultural Wellness Center, requires some amount of self-study. It also, like many of the critical theory approaches, the decolonizing research approaches, it raises epistemological questions and challenges. And it may, like the work of the Cultural Wellness Center, see a benefit through the research process as well to the research participants. In the case of the Cultural Wellness Center, through that self-examination process, as well as the benefits that we think of, which are typically in the outcomes of research. So, one point I want to make is communities are not monoliths. And so if we think about different communities, they're going to have different orientations to research. They're going to want to work on research at different places on that spectrum as well. Both BIPOC scholars and white scholars also might gravitate to different ways. So I don't want to be suggesting that communities all want to work one way and certain sets of scholars all want to work one way or another way. So I'm gonna present two case studies to kind of go through some of that grouping and help make a few of those points a bit clearer. So I chose this case that's one that's been was in the press and also has been written about by bioethicists, and is also one excuse me, that I've used for training in the past. So the Havasupai tribe is a tribe that is whose ancestral homeland is at the base of the Grand Canyon. They had a longstanding and a positive relationship with the anthropologist from the University of Arizona. They were concerned about the extremely high rates of diabetes in their community and the negative health impacts it was having on community members. And so they asked this collaborator if there was someone who could help them understand whether there's a genetic cause to this. And so could there be a potential cure? So he reached out to a geneticist who came at the tribe's request. They developed a study to understand, try to understand. So this was, not long after the time that the Pima American Indians, that there's some genetic identification of risk for diabetes. So this is sort of the type of thing they were looking for. Informed consent was completed. It was broad in what the blood samples could be used for that were taken from the tribe. Tribal members were very supportive of this, were very much involved in recruiting family members and others to be part of the study. It turned out that the genetic markers that they were looking for didn't exist. And so sort of was a null study from that perspective. But the blood that was gathered went on to be used for other purposes. So to study genetic factors for conditions like schizophrenia, and then also to look at one published article reported the origins of the Havasupai as Asian coming across the Bering Strait, which was in conflict with the tribal elders' descriptions of the ancestral homeland and the origin story that the tribe held to be true. So the Havasupai brought a lawsuit when this was discovered. Ultimately, it was settled and the blood samples were returned to the tribe. So no formal ethical human violation, human subjects violations were ever identified. And what came out was an example of a deep deep distrust and deep differential understanding of these issues. So the tension points were kind of twofold. They were really about process, and then they were about culture. So if you look at process in sort of these kind of three types of engagement, you could say that there are some examples here of strong community engagement. The Havasupai invited the researchers. It was built on a long-term partnership with the anthropologist. Tribal members were involved, wanted the study to happen. And the outcomes were really the outcomes that were defined were really the ones that they asked for. But there really wasn't engagement for equity. So they could have actively involved the tribe from beginning to end, including thinking through what the consent process looked like and explaining more explicitly what it meant. They could have involved Indigenous researchers who might have identified problems earlier. They could have considered Indigenous data sovereignty, which is one of the recommendations from Indigenous scholars that's come out of this case and others. And they could have reported results back along the way so that they could have gotten insight from the community about the negative impact that the study might potentially have. And that cultural dissonance is a big part of what this is. So if on the part of the researchers, they had both had a better understanding of the Havasupai cultural orientation to this work, and if they had done the self-examine of their own orientation to the work, anticipated the areas of conflict, it's possible that some of this could have been avoided. So the second study I want to walk you through real quickly is an example that moves us further towards the positive impact of thinking about engagement. And it's one that if you've heard me speak before, you may have heard me talk about this. Community Partners in Care was conducted by two of my sort of mentors in community engaged research, Loretta Jones, who fortunately passed away recently, but was the CEO of Healthy African American Families in Los Angeles, and Ken Wells, who is in psychiatry at UCLA. So they've collaborated on research focused on depression care for South Los Angeles communities for over 12 years. And this study, I think, is important to highlight and talk through because part of the intention of the study was to prove that using community engaged approaches in research around in this case, depression care, was better than standard care. So it's a randomized controlled trial that was funded by NIH. So the design of the trial involved a council of academic and community leadership using their version of community-based participatory research, which they called community-partnered participatory research. They worked in 2 under-resourced communities in Los Angeles. They enrolled and randomized 92 community-serving organizations, including clinics, homeless shelters, and other service organizations. And then in those organizations, they enrolled over 1,200 clients. 41% of them were Latinx and 46% were African American. So a huge study at multiple levels. And what they found is that the participatory approach versus usual training did get better outcomes. So it resulted in decreased behavioral health hospitalizations by about 50%, increased appropriate care, meaning that they decreased visits to specialty mental health clinics and increased people being treated in primary care. They decreased homelessness and risk factors for homelessness by 25%, which is important because that was not one of the proposed initial outcomes that they were going to look at, but that was one of the ones out of the collaborative process that community thought was important to look at, both from a policy perspective and because that's where they thought they were going to make the most difference. And it ended up being, one of the important outcomes that they identified. So when you look at this study across these 3 buckets, they worked with many community agencies, so it was very grounded in the end users. They built on the Healthy African American Families reputation for action. In addition to the patient-oriented outcomes that I just mentioned, in this case, it was community-oriented outcomes. The community input also improved the trial design. And I'll talk about that if we have a chance or anyone's interested. This was a study who really framed engagement for equity. It was built around a community council with clear community leadership. There was an equity orientation that was implicit, although again, it was not explicit. The collaboration really had institutional effects that led to institutional change and drew from institutional change. So Loretta sat on the IRB at UCLA. Ken sat on her board. Healthy African American Family staff became community faculty at one of the affiliate hospitals with UCLA. So they really sort of did center at the margins by explicitly developing approaches and processes that centered community voice. And as I mentioned, they had novel policy outcomes that resulted. So culture here was highly aligned. They had found what I'm going to describe as the sweet spot, that's the overlap between community and academic knowledge, but was not reconsidered. So this was a randomized controlled trial, and that's what this community partnered participatory research really tries to do. They didn't address underlying systemic barriers, and so that was one of the concerns that was raised by partners over the long term, is the ability to sustain it, because the underlying sort of funding structure that would go on to support how depression care happened in these clinics didn't get a lot of change. And then the last piece, that benefit through the research process as well as outcomes. I don't know that I can answer that, because I feel like I would be speaking for Loretta, which I don't think I can do. But if I had to guess, I would say she would probably say there is some of that, but I think that that would be different from maybe the process that the Cultural Wellness Center would talk about. So the bottom line in thinking about all of this and thinking about how we're doing our work is needing to constantly keep at the forefront of doing good and minimizing harm. And I have the picture of Eunice Rivers here, who was the nurse who led the Tuskegee syphilis studies, because I think that as people who are promoting community engagement, we need to be mindful of the ways that we are at that edge of risk, where if we don't do this right, not only are we damaging our own reputation and our own ability to do work, but we are also damaging that of the people that we bring in to collaborate with us to do this work. So how do we then go on to find that sweet spot, as it's been described at the Cultural Wellness Center, between community knowledge and academic knowledge? And they have a very nice way to talk about the principles of cultural interfacing. And I would like to talk more about it. I'm going to read it very quickly and not in detail so that we have time for conversation. But it is the philosophy of community, that all interactions build community, and we need partners to do this work. Knowledge production, where both partners are teachers and students. Multi-level strategies, the level of sickness and disease in our communities and complexities require multi-level strategies, and we need a holistic and comprehensive approach. Partnerships require active collaboration and looking for solutions outside of conventional ways of thinking, and that the partnerships themselves are opportunities for modeling health. And that would mean that connections, creating knowledge in coming together, and protecting cultural knowledge. The partnerships respect that cultural knowledge belongs to the cultural communities. So I think that some of these principles begin to help us to think, how do we work at that interface? So if we were to take community voice seriously in thinking about doing the work, what are a few of the steps that we would want to be more explicit about taking? So one, I think, is to do good, rich, community engaged research, which means to enhance training, opportunities for learning on both sides, and guidance, particularly on the part of academics, but also on the part of communities. And we need to make our equity orientation and goals explicit in the definitions of community engagement and the tools supporting the work. I think we need to collaborate with critical theorists to identify opportunities for examination of research processes. I mean, we've got to look at these problems, look at the tension points, and see what kind of solutions we can propose. And we need to collaborate with organizations such as the Cultural Wellness Center, who offer opportunities for self-study of our institutional cultures. So coming back to those framing questions, I hope that we've sort of at least started to answer around the edge of the first two questions. But I think that third question about implications is one I hope we can explore more now in the question and answer session. Thank you.
Thanks so much for that, Michele. That was very helpful and thought-provoking. I see we've got a couple of really interesting questions in the chat. So let me just remind folks, or in the Q&A, let me just remind folks to use the Q&A function. If you can, it's located at the bottom, I think, at least on my screen, the bottom right hand of your screen. If you can type your questions in there, that would be awesome. And we'll be monitoring those and raising those issues with Dr. Allen now. A couple of really, I think, super interesting questions here. Let me pose these to you. The first one is, in what way or ways Do you think that the discussion of caste, as recently examined by, for example, Isabel Wilkerson in her 2020 book on the topic, provides a useful additional overlay or lens to those dimensions of race, class, and gender in how we address equity, engage with communities, and reduce disparities? Does it complicate those efforts in any way? If so, is that complication potentially positive? So there's a lot to reflect on in that question.
Well, particularly since the book is sitting on my nightstand and I haven't read it yet. But from what I understand about the book, and so I'll answer it kind of at a high level, I do think that that this idea of caste groupings, kind of self-organization, which includes, all the isms, a lot of the complexity about how we class, all of those sort of things. I think fundamentally what it raises, are we in some way sort of wired to divide ourselves? And if we are, how do we be more explicit in terms of thinking about how overcoming some of those issues? And I think that I think this is like sort of me being more kind of, I guess just I'll call it touchy-feely the older I get, but that self-reflection process and understanding is really sort of like such an important part of any work we're doing, equity work we're doing, sort of anything from the individual sort of implicit bias, trying to understand our own implicit biases and sort of be aware of our own personal behaviors, to thinking about ourselves and our collection of social beings and how we self-identify and what that means for other people, and how the power we hold affects those interactions with other people. So I really do, I'm going to come back to the Cultural Wellness Center as one kind of way to think about this. There's a number of people doing work on mindfulness and race, for instance. Ruth King is one person who comes to mind. Any of those processes where we're taking kind of assumptions and trying to bring them to the forefront to examine them and understand how they're affecting us and those around us, I think are going to be helpful.
Thanks. I'm going to follow up with another question in the Q&A that I think is about framing in a way that kind of connects with what you just said. And the question says, there's talk about assets, but why the deficit terms used so often in research? So why focus so much on disparities and marginalization and so on, rather than using language that is in a more positive way focused on justice or promotion of justice? I wonder if you can reflect on that.
Well, I mean, I think that it's heartening to see that we're moving in that direction. And I think that, again, that's where a lot of our, at least in my own experience, my BIPOC colleagues are really sort of raising that and asking the hard questions about that. The deficits frame is, I think, what I think is baked into us, and another one of those things that we just need to become more aware of in the way that we are taught to do research, right? Or we're taught to be clinicians. It's problem orientation. There is a problem out there. Let's sort of call out that problem. Let's highlight that problem, and let's talk about how we're prepared to fix that problem. And it's an issue in grant writing. I, had an experience with a community partner very recently where, she was not happy the way that we were framing our NIH proposal. And, we had to have a lot of conversation about what are we asked? Where can we push back? How can we be more explicit? How can we think through both those concerns and trying to be pointed about challenging that framing, while also getting our work funded so we can do our work together. So it takes constant creativity, and it takes constant, I think, sort of listening and learning from each other.
Indeed. I want to say it's complicated, isn't it? So next question, how do these methods avoid some of the traps found in clinical outcomes research funded by companies with material interests in the results?
So I want to be optimistic and believe that even companies, and I gave a talk from this perspective, was asked to speak at Medtronic not too long ago. I think that even companies who have a financial interest can do this work and can do this work, should do this work better. If what all of us are saying is that we want to impact health inequities and we want to reduce health disparities, I think that, which is a part of many corporate missions, right? Corporate, they want to have wellness, and particularly I think our local corporations are, because of the murder of George Floyd, are also being compelled at the moment to ask these questions themselves. And so I do think that they can and should be asking themselves the same questions. They have a different set of challenges in terms of who they're speaking to shareholders. We're speaking to NIH, and so there is that constant pushback. But I think that what we can't do is say it's not part of the conversation. So we really just have to say it's part of the conversation. The solution may not be immediately apparent, but we need to sort of bring it into the conversation and ask the hard questions.
Thanks. The next question really relates to one of the issues that you raised in your talk around sustainability. You raised it specifically in the community partners in care case. But one of our colleagues thanks you for your beautiful overview and then says that they want to reflect on how applicable this topic is to global health research as well. So one of the ethical challenges that this questioner sees with this type of research is that oftentimes our communities and partners are expecting real deliverable impact from the research that we do in the form of systems change or policy change or meeting a particular need, but that's unfortunately not what happens often, right? The studies get done, the papers are published, but the implementation doesn't follow. And so the question is, what advice do you have for researchers and funders on that translation or sustainability piece?
So I think that that's dissemination and sharing back knowledge in a way that's sustainable really is kind of a core principle of participatory research. And I know that particularly Salamo Partnership for Health and Wellness and those partners, have thought a lot about, dissemination, translation. How do we think about making sure that at the onset of the study, sort of particularly at the time of budgeting, we're thinking about dissemination. So usually we're pushing our studies all the way up to the last possible time point for data collection, and we we struggle with recruitment, all these sorts of things. But if you don't sort of hold that commitment to dissemination money, thinking about dissemination, then I think that the person that asked this question is absolutely right. The default is that the study wraps up and we leave. And so one thing that could help is we're through CTSI CEARCH and Program on Health Disparities Research, we're developing a community engaged dissemination toolkit that we're going to be rolling out in the next couple of months that will hopefully kind of simplify that process, because it's not easy. None of us are trained to do dissemination, right? It takes graphic design. It takes sort of, creative ways to share knowledge back. It takes people who know how to do systems change in maybe a way that we don't know how to do it. So what we tried to do is it's sharing a process and sharing resources, and hopefully kind of demystifying what some of that can look like at that end of the study. But I guess my overall recommendation is plan early, think early, make it part of what you're seeing as the outcomes of the study.
So let me follow up on that a little bit, because I think, it's fantastic to provide that sort of toolkit. I think that's going to be enormously helpful, because my sense is that you're right, that there are a lot of people who would like to engage communities in a more equity or transformational way in their research, but a lot of us are not trained to do this, right? And need some support and help with that. But I also wonder if you could talk about some of the other sorts of challenges or hurdles. I don't want to say barriers quite, because it's that negative framing, but issues around, is there really funding? So if you're trying to plan in the way that you're talking about at the beginning when you're putting together your budget, and that your, call for proposals says that you have X limit on your grant, and it's going to take however much money to fund you and your community partner and the research activities and so on. Do we need funders to change the way they fund research? Do we need universities to change the way they evaluate or support research, or the careers of researchers? What do we need to do to make the work more possible?
How long do we have?
we have 15 more minutes. I'm sure you could talk about this for a long time. I know it's a broad question, but have at it.
So I think that we do need funding for dissemination research, and we've sort of in the Program of Health Disparities Research in our pilot grant, we have switched to explicitly funding dissemination research. So I think that we need more opportunities for funding. And I think, in that whole realm of dissemination and implementation science, there are more opportunities out there. AHRQ, NIH, PCORI. So some of those are willing to consider sort of dissemination type of studies. The science of dissemination and implementation is just exploding, and the methodology, I think, is getting a lot stronger. I will say not a lot of it is community engaged, and very little of it takes an equity lens. So Brooke Cunningham and I have done a little bit of work and have a paper coming out on that regard. I do think that I do think that there are more opportunities. People are seeing, that we need to be doing that, partially to just get the benefit of research out there, also because of our commitment to communities. So there's a lot of people who would say that we really don't reward as academic institutions. And I think that, we're probably further along than some other institutions here at the University of Minnesota. And I would credit Andy Fricko with some of that, with thinking about ways to support and talk about the benefits of community engaged research. So still, it when your tenure is really sort of dependent on traditional publications rather than community impact, there's tensions there, and so there's definitely work to be done, and people have been thinking about that, and I think we'll continue to think about that, but it is true, there's a disconnect. Was there another part of your question?
No, I think that I just invite you to, weigh in on any sort of path to, change, really. I certainly have heard of discussions both at the level of funding and at the level of institutional support. But if there are other things that you think are important, it would be great for those to get raised up at this point.
Well, the other sort of piece of it, a lot of when you community engaged research, a lot of it is sort of bringing, in some sense, us stepping out of the ivory tower to collaborate with community. And the other opportunity, I think, is to bring community into our decision making within the university in a more explicit way. And so we have at CTSI CEARCH, we have a management council that has community representation. PHDR has a community academic board that sort of helps us set priorities and strategies and create, strong connections with community. There's a number of initiatives going on sort of across the system, sort of with clinics and family medicine, where they're trying to do stronger and more explicit community engagement around clinical practices. So I think that idea of bringing community into institutional change is kind of there's a lot of opportunity to kind of push us and propel us towards change through that avenue as well.
That's helpful, thanks. I also want to ask you a question about a point you made at least a couple of times in your talk, which I think is interesting, the issue about whether programs that engage in community-based participatory research, or that promote or support that sort of research, have a kind of implicit commitment to equity or an explicit commitment to equity. And I'm wondering if you could speak to that difference a bit, and why that commitment tends to be more implicit than explicit, given what you said, and what difference it would make in practice for us to be more explicit about the equity connection. So from an ethics perspective, for years, I have thought about community-based participatory research primarily through an equity lens, but it's clear that not everyone does. So, if you could just speak to that.
Yeah, I think that many CBPR researchers do. That is very much a part of their orientation to the work. And yet, I think that intersection between kind of more activist equity work that is coming out of the community, and some from some BIPOC scholars, and the desire of institutions to be more equitable really calls us to make those practices more explicit. And really, when you start getting down to thinking about what are equity promoting practices, they are a number of the ones that I listed earlier. They are being mindful of how you work together. They are not making assumptions. They are the ones that CBPR and the list that I presented earlier was our local PhDR board's sort of take on those. Those are really equity promoting practices, and yet we haven't called them that. And so I think that it just puts a fine point on what we're trying to do. And it also makes us ask more explicitly as part of those practices, okay, is this going to have benefit? Who is it going to have benefit for? And does that mean that we need to, if it's a differential benefit, do we need to rethink it? So it's just, I think, really, we need to go back, we need to think through those practices, and we need to really sort of say, here's the piece that is explicitly linked to equity. Here are pieces that are good practices that are going to get us to help us have good group process, but maybe they're less central to the equity work, and making sure that we're highlighting the ones that are really going to promote equity. And then if we're saying that there's a link between community engagement and equity and research, then we need to be asking, who else needs to be doing community engagement? Right now, it's sort of, this is the opportunity that I see in working in the CTSI through our CTSA is there's a narrow band of people who are really doing deeply community engaged work. How do we expand that group of people if what we're saying we want to do is to have more thoughtfulness about equity within our research? So it means really kind of broadening the opportunities for more types of research to be community engaged.
So that's a perfect segue to the next question in the Q&A, which is there room in community-based participatory research for community-owned and managed research, or does that not fit in academic culture?
I think it does. And so I think that's, so a lot of the folks that do CBPR would say that the natural evolution of the process is to have community expertise developed to the point that they become the drivers of the research. So, but that's again said within the frame of everyone aspiring to kind of have traditional research expertise and to be doing the type of research and the way that we're doing it. And I think that there is a call and a need for that, but I think we also need to have space and be mindful of what the Cultural Wellness Center or what a lot of the Indigenous researchers really talking about decolonizing research would say is that, research could look very different and have a very different meaning. And that should be community driving that.
So that's really the transformational piece.
Right.
Yeah. Yeah. Well, thank you. I mean, this has just been so interesting and so helpful and thought-provoking. I really appreciate that you took the time to share your perspective with us today, and hope that we can kind of continue to have these conversations, because these are really important issues, I think, and very much, as I said initially, sort of at the intersection of research ethics on the one hand and equity or justice work, which is a lot sort of core to bioethics on the other. So we're just about out of time. I want to take a moment to, if you could flip to your next slide, Dr. Allen,
Yeah.
let people know about our next event, which is also a research ethics focused event that we will be hosting in partnership with the Human Research Protections Program here at the university. It's going to be a panel discussion about lessons from the COVID-19 front lines of conducting research. So the panel will involve folks who really have been actively engaged in conducting and doing oversight of COVID research, and sort of reflecting not just backward on the challenges that have arisen in that context, but sort of keeping in mind those issues about what lessons do we learn and how can we transform practice. What does that mean in terms of what lessons can we learn about doing a better job with research moving forward? So um, I'd ask you to save the date for Monday, March 29th for that panel discussion. You can see that it'll be 2:30 to 3:45, again over Zoom. And we look forward to folks' participation in that event as well. And let me just one last time say thank you so much, Dr.
Thank you for
Allen,
having me.
for joining us today. And thank you to our co-sponsors again for their support for this event, and for all of you for joining us. And we look forward to seeing you next time.